morning, everybody. Good morning. Okay, come on, we can do better than that. Good morning, everybody. It's a beautiful day, and I am so excited to be here. Thank you so much for having me. And I'm going to get a little academic, but I do, as Erica said, thank you so much for the very kind introduction. I do want this to be an engaging process, in between your bites and things like that. At least it would be for me in between my bites. But I do want this to be an engaging process. And I am really grateful for this opportunity. And I want to talk about migraine disease. So first, let me start off by saying that headache medicine, that there are over 300 different headache disorders. Over 300 different, and did somebody say, geez, that's what I said. I was like, wow, right? And how did I get into headache medicine? So I'm gonna fast forward because I know they only give me a certain amount of time, but I'm gonna fast forward. But I got into headache medicine because of what's called hemicrania continuum. Hemi, what's that? Is that something in my truck? No. Hemi is half, crania is head continuum. So it's a continuous headache that occurs on one side of the head that is associated with different autonomics, so your fight, flight, rest, and digest, but in your head, right? And I'm thinking, oh wow, this is migraine disease, and my attending at the time, and I was at Houston, I was at Baylor College of Medicine, is where I did my neurology residency, and he said, have you thought about hemicrania continuum? I'm like, hemi what? Hemi who? So from that point, being the nerd. So it's okay to call me a nerd. So they used to call me a nerd in high school, but I was a cool nerd. So I was a cool nerd. So I own that cool nerdiness, right? So on my vacation, I grabbed this book called Chronic Headache Disorders, and then I started seeing about all these different classifications of headaches, and I had no clue. But what I did realize is that if we have the right headache diagnosis, that we have the best opportunity to treat people and for them to have their optimal care and live their life. So this little molecule over here is a molecule I'll talk about. This is actually calcitonin gene-related peptide, which is CGRP. I'll talk about that. And this molecule, no, that is where I was. So let me go through. I always talk about my disclosures and things like that. I will say that there are no relevant disclosures for this talk, but I always like to put that on there, just kind of, it's not seeing me, but just as good practice, good standard practice. So been blessed to serve as a consultant to a lot of different companies and things like that. So moving on, I will be moving back and forth. In fact, I might sit here because this is breakfast with a doctor, right? So you guys are having your breakfast. So I'm gonna go to the slide here. It won't work. So I'm sorry, I have to go. I was at the food table. Now I have to go back over here. So
It's your seat here.
yeah, my seat here. Okay, so I already sat there. It's already been warmed a little bit, right? So okay, now what am I going to do? All right, I really want to debunk some myths. Actually, go out here and these myths are live and relevant today. So this week, actually two of the myths that I'll talk about, my patients have experienced. So in all seriousness, I want to have fun, but I also want us to understand, like, what is migraine disease? Why do I keep saying migraine disease? Why am I not saying migraines? Why am I not saying migraines? I'm glad you asked. We're gonna get to that, okay? So we want to firmly debunk these 5 myths. There's more, but 5 myths of migraine. Just an overview of epidemiology of migraine disease, the pathophysiology. So again, if there's questions, please let me know. But that's implicated in newer migraine treatment, right? In fact, when I remember when I wanted to be a neurologist. So my 5th grade career research paper was I want to be a neurosurgeon and own my own office of neurology. I told you I was a nerd. All right, so I wanted to own my own office of neurology. Didn't know the difference between neurosurgery and neurology. Didn't know that difference. And one of my mentors said, "Why do you want to do neurology? That's just diagnosing adios." I'm like, no, it's not. Diagnosing adios. So I'm going to share how we've advanced, even in headache medicine, where it is no longer diagnosing adios, okay? Because we're starting to explore the targets. We're starting to have the different innovations and things like that to be even more specific in our disease care. So it's not diagnose and adios, but we are going to appreciate, hopefully, we appreciate the diagnosis of migraine. And then I'm going to talk about some of these common things within these myths of tension type headache. Okay, what's the difference between tension type headache and what's sinus headache? So we're going to do that. So welcome to this journey. All right, let's go. Okay, and I am going to ask for a little bit of participation. Okay, and you'll get out. I'll tell you in just a moment. So myth one, migraine is just a bad headache. How many of you heard someone else say something like this? Migraine is just a bad headache. It's just a bad headache. Okay? And this is where your participation will come in. I'm gonna start here first. Okay, that's good. Can everybody give me a little bit of all right, we hopefully get better. We got 5 minutes to cover, so hopefully it will improve. Okay, so and when I did that, I said that with my daughter. I have an 8-year-old and a 4-year-old. Oh, they just loved it. So I'm like, I hope my daughter's too. Okay, so migraine. Yeah, just it's a little bit older, all right, a little bit older crowd, but I hope they still love it. Right? So migraine is a chronic neurological disease with episodic manifestation. Okay, there's a lot of stigma when it comes to headache. There's a lot of stigma when it comes to migraine. And a lot of times we have stigma about things that we don't quite understand sometimes. So I'm trying to help illuminate, hopefully, this disease. It's the second most disabling neurological disorder in the world. Okay? And I tell my patients sometimes, I said, I'm going to tell you what the evidence show and what the books say, and I'll tell you what I think. Well, I'm going to tell you what the evidence shows, okay? So if you look over here, what's number one? Number one, stroke. Stroke is bad, okay? What's number 2? Migraine. These are all the different, this is global right here, all the different countries. In some countries, migraine is number 1, right? Sometimes it's number 3, but overall is number 2, okay? I mean, higher than Alzheimer's, higher than meningitis, epilepsy, tension type headache, encephalitis, Parkinson's disease, multiple sclerosis, things that we hear about a lot, right? And to me, I'm like, wow. So why is something so stigmatized that is so, because it's an invisible disease. It's an invisible disease, and it's very hard, like even with trying to get biomarkers and things like that, it's very hard to put your finger on it because it's an invisible disease. But it's not to be over here. There we go. But let me talk about the anatomy of a migraine attack. So, and we'll come to this again. So if you don't get it now, that's all right. Hopefully we'll get it by the end, right? Where I can show you where our evidence share the different areas of the brain. So migraine, notice I say migraine disease. Migraine is a syndrome. It has different phases to it. Okay, it has different phases to it. And we've been able to map those different phases to different parts of the brain. So premonitory phase has been mapped to the hypothalamus, the brainstem, the cortex, the aura, mapped to the cortex. The headache phase, which most people think, okay, remember, they think it's just a bad headache, right? The headache phase maps to other areas of the brain, brainstem, thalamus, hypothalamus, and also some of the cortex thalamus as well. And post-strong, we're still trying to figure that out, okay? And this post-strong, which I'll talk about a little bit later, is kind of this brain fog. In fact, I just came back from San Diego last week. We had I told Mrs. Erica, and we had our American Headache Society meeting. And one of the things, one of the plenary sessions was on brain fog. And I've been, but nobody really asked me what I think, but I've been talking about brain fog for years because I've been trying to figure out, hey, when my patients come in and when they say something, it's just, I mean, I just can't think, I can't concentrate. It's like I have a hangover after I had this attack and everything. And I mean, at least we're getting to it now, right? I mean, it literally 7 years ago because the FDA has started to look at, hey, what's the most bothersome symptom? Well, if we let people tell us what their most bothersome symptoms, they'll tell us. But if we only give them 3 things to challenge to select from, they're telling us their most bothersome symptom from what they have. Well, I mean, if it's nausea or licensed to be or something, I mean, well, mine is this. But this has been really impactful. So this is an area here, this post-stromal or resolution phase, that we're really still trying to find out, hey, what's going on? And we're looking at this now again. Now, this is a complicated slide. Well, it's not it's a slide, it's a table that looks at all these different neuropeptides. So peptides is simply proteins. So these neuroactive substances, vasoactive substances, and things like that, or chemoactive substances that are implicated in migraine biology. Well, it's a lot. Right now, there's a lot of medications with CGRP, which stands for calcitonin gene-related peptide, because we know that that's a big part of migraine pathophysiology. Okay, but there's other things. This is coming soon, hopefully. PACAP, which stands for pituitary adenylase cyclase activating protein. Just easier to say PACAP. Okay, all right, PACAP. And this is again being tried in studies and things like that now. And some of these have been tried before. Vasoactive protein, neuropeptide Y, and orexins are actually being explored now. Leptin. So this is the association that migraine has with obesity. Right, there's an association there, and so I think that leptin has a role to do with that. Some of these other ones, and then I'm going to say POMC and CART. So my point of this slide is just to say that there are different parts on the molecular level of migraine. Right, so we're not just talking about a headache. Remember, that's the myth that we're debunking now. I think over here, I wonder if I'll put this way, if it would. Oh, let me go back. Okay, so the last slide on this, and this kind of reiterates some of the different points that I've already made, but it's looking at, again, the implications of management. So this is not going to be a management talk, but just looking at the different parts of the trigeminal trigeminal cervical system, the brain, and we had a debate of migraine is activated inside the brain versus outside the brain. I think it's actually both, right? And it's not it's not a monolith, it's heterogeneous, right? So it's all over, not all over the place, but it has a lot of different inputs. So the cortex and the thalamus, and you talked about these, the trigeminal cervical complex. This is where people they get this neck pain first and everything that happens because it's a brain disease where there's activation of a brain disease that's happening, and the innervation of the cervical spine, upper cervical spine, is in the back of the head and the neck. So it's not my neck is causing this, it's that you have a brain disease that's being activated. Your neck is a bystander of that activation, as well as the head pain that people experience. Okay? And then we have a lot of different neuromodulation now, so different devices that target these different areas. So, all right, next myth. Now get ready. All right, you got to imagine that I'm debunking things, so we got to imagine what the next slide is going to be. Okay? Migraine affects only women. What's the sound? And all right, let's try that one more time. 1, 2, 3. And all right, awesome. Cool. All right, okay. So I already talked about that this is a common problem, but it's also a common problem that's underserved. So yes, it's about 2 to 3 to 1 in an estimated prevalence. But what does that mean? Okay, that means that it's about 30 million plus women. So almost 1 in 5 women have some form of migraine disease. Almost 1 in 5 women. But almost 1 in 16 men have migraine disease as well. That is not a rare disease. Okay, let me put it in perspective. Multiple sclerosis. So multiple sclerosis was when I went into and finally did neurology, that was because my good dear friend, still a good, was best friend at the time, not my wife, so not my best friend, but still a good dear friend, I was there with her when she was diagnosed with multiple sclerosis. Terrible disease, right? Terrible disease, which they've had a lot of different advancements, especially since I've gotten out of residency. But let's put this in perspective. This is way more, 10 million people. This is not a rare disease. Cluster headache, which is a different headache type, is on par with the prevalence that I saw with multiple sclerosis. So, I mean, it's under 1 million. So it's somewhere between it, and they feel like it's being underdiagnosed thing as well. So somewhere between 400 and 600,000. That's a good ballpark. 10 million. So this is not a rare disease. That's why you can think about, you know, I play football, and I like that it's 11 people that's playing at one time on each side of it. So it's likely that, you know, at least one of those people that are playing have migraine plus the team. So there's people on the play, and we've seen it. We've seen Percy Harvin, we've seen Terrell Owen, we've seen some of these NFL athletes that have, and this is not talking about concussion, which is another, which can have another headache associated with it, but this is just talking about migraine disease. So not a rare disease, but I figure I'll use this to talk about the prevalence. And when we look at this data was published, not everybody can see this, but this data was published back in 2021. But if we look, published back in Neurology in 2007 by Stewart and Lipton and all, the curve looks the same. So yes, there's a big proportion in younger age, right? Big proportion. You see, as people get older, through menarche or when people have their first period and everything like that, then you start to see this separation. So we're thinking that there's some hormonal component, but it's still not men, right? It's still men. This is so these are in the millions, okay? So this is between 40 and 60 million, and this is a global prevalence. And so again, not a rare disease for men. And we see this, and we see it across the lifetime spectrum, okay? A little bit decrease that happens after postmenopausal and things like that, but we still see it. I mean, I still have patients in this category, okay? I still see patients and try and honor to care for patient in that category. Okay. The purpose of this slide is just to show that, again, it's a chronic brain disease that have episodic manifestation. If you get to the chronic migraine diagnosis, you have significant impact on healthcare resources, on quality of life, on medical and psychiatric comorbidities or co-occurrences. We're starting to use that word, co-occurrences. So it's one disorder that happens with another disorder that happens more than chance. They kind of ride in the same car, okay? And we see that with a lot of different medical and psychiatric comorbidities. Now, in fact, some of those are risk factors. Like, so depression, by the way, is a strong risk factor for progression from episodic to chronic migraine, as is what's called medication overuse, okay? With acute medications, unfortunately, there's a threshold that if you use it based on days, okay? Based on days, and there's a criteria for that. I won't get too deep into that, but that's a strong risk factor that's modifiable. So what I'm talking about are things that are potentially modifiable. Obesity is modifiable. Asthma, which is associated, excuse me, is modifiable. So, cheers. All right. So again, chronic disease affecting both men and women, right? So now let's move on to myth 3. It's not a true aura if it doesn't start, not a true migraine if it doesn't start with the aura. Or sometimes stated as, to get a migraine diagnosis, you have to experience the aura phase of an attack. What's coming? 1, 2, 3. All right, we're getting better. Okay. So this is what I had a patient that came in with this, with that statement, and years. And this patient was, oh, thank you so much. This patient was 63 years young that I saw yesterday, literally. And their diagnosis was delayed. And then I also had a 23-year-old, was delayed because they didn't have aura. So let me talk about what aura is and talk about how it relates. So this was first described in 1944, right? And it's a slow waving, propagating wave of what we call depolarization. Now, they used to call it depression, but it's really a depolarization. And it's followed by some different corticals. So that's on the outside of the brain, the cortex, for inhibition of that activity for 30 minutes, right? And so what happens is that it is associated, hopefully you can see this, it is associated with a wave of hyperemia. So this is just a lot, so kind of a lot of flow, essentially, and with increased neuronal depolarization, and then followed by cortical oligemia. So like it's lesser. So they're getting less. The cortex is getting lesser of the nutrients that it would normally get. Okay, and you get decreased neuronal polarization, and we can see this in in imaging studies such as EEG or have you. But I have a video here, and this is this is induced cortical waves and migraine in this animal model. So, and you can just see that. Look at that. It's just spreading. It's a slow spread. Usually 2 to 3 millimeters per minute, but they can go 2 to 6 millimeters per minute of this spreading across the brain, right? And some people say migraine is all in their head. Well, if you consider your brain is in your head. Yeah, absolutely. Getting activation, right? So let me discuss the phases of migraine attack, okay? Again, I talk about migraine being a disease, migraine being a syndrome. And so there's premonitory symptoms, right? So these premonitory symptoms, I mean, it can be fatigue, it can be food cravings and cognitive changes and yawning and things like that. And this usually happens hours to days before a headache attack, okay? Then this is the aura, right? So this is the thing that people think about with a migraine and have this aura, okay? It's usually 5 to 60 seconds. It's fully reversible neurological symptoms, all right? Usually followed by a headache attack. And a headache attack usually lasts from 4 to 72 hours if not treated or unsuccessfully treated. That's the usual time. And it can be throbbing, it can be burning, it can be some sensitivity to light and sounds and smells. You have mood changes with the headache attack. And then you have post-stroke, right? So post-stroke, again, I talked about the phase, we're trying to understand it better what happens in the brain, but it can last from 24 to 48 hours. I mean, you can have the euphoric mood, you can have a depressed mood, most often it's inability to concentrate or think straight or things like that. And so different cognitive changes still can have neck stiffness or what have you. So these are the different phases, and then some people may include the interictal phase, so the phase where nothing is going on, but you still have migraine disease, but nothing is happening. They include that as maybe the 5th phase. So you might hear anywhere from 4 to 5 phases, and that's what you mean. But this aura phase, so here's the diagnosis. So we're going to just do this real quick. So our diagnosis is based on an international classification of headache disorder. So at the beginning of the talk, I started saying how there's over 300 different headache diagnoses. Well, that's where that's like our headache Bible in a sense, right? That's the international classification, so ICHD. We're in the 3rd version. The 4th version is actually ongoing. The committees are meeting now for that, but that's where we get our headache classification. And when we look at migraine without aura, right? So you have to have at least 5 attacks. The headache phase lasts 4 to 72 hours, untreated or unsuccessfully treated, like I just shared. And have to have 2 or more of the following. So unilateral location on one side, pulsating quality, so that's kind of that throbbing, moderate or severe pain intensity. And I have to share and educate a lot of my patients too, because they think, oh, it's most severe pain. It's like, no, actually moderate headache. A moderate headache attack qualifies for a migraine headache attack. And then aggravation or causing aggravation of routine physical activities and things like that. Then you have to have 1 or more of the following, which is nausea and or vomiting, or phonophobia or photophobia. Phonophobia, sensitivity to sounds, photophobia, sensitivity to light, but also not attributable to any other disorder. Some people sometimes forget that, right? So I have people that want to get imaging and everything, and I mean, like serial imaging. I had a patient yesterday, well, I'm going to get similar serial imaging. Well, you already had different imaging. And by the way, evidence would suggest if your neurological exam, if you have stereotypical migraine features and your neuro exam is normal, your exam, you have a 98 point, almost 99% chance of having a normal MRI with maybe you see some insulinophinus or what have you. And so we usually don't get it, it's not recommended. I know people ask for it all the time, but that's why we're having this talk and everything, so people understand what migraine disease. There are some certain circumstances where you will absolutely get neural imaging. That's actually one of the courses that I instruct at the Jefferson Headache Center, the diagnostic and imaging course. So there are different places, but usually migraine is a clinical diagnosis. All right. Now, migraine with aura, there we go. Migraine with aura, so you have to have 2 attacks of fulfilling these criteria. So the aura, again, is a reversible neurological symptom, right? So it can be visual, which is most common, over 80% is usually visual, sensory, speech, or language, motor, a brainstem or retinal, right? And then you have to have at least 3 of the following. And the purpose of, when we look at this, I would say, like, if you look at number 6, right? Number 6, the aura is accompanied by or followed within 60 minutes by a headache. So don't necessarily have to have that if you have the other criteria, right? So it's gradually spreading. You get 2 at more time. Usually 1 aura is unilateral, so same side. 1 is positive. So positive versus a negative symptom, which get to, go ahead. So I'll get to in just a minute. So positive symptoms is like when you see extra stuff, right? So if you have numbness, that's negative. If you have tingling, that's positive. That's additional, right? So it's positive. So the same thing. If you see more colors, that's a positive thing. If the vision decreased, that's negative, right? So a negative versus positive neurological symptoms. So, and that becomes important, like when we're trying to differentiate from, is it a transient ischemic attack? Is it a seizure? Is it just neurological focal deficits and things like that? So that's something that's important. So back to that myth, only 20 to 30% of patients have experienced migraine disease with aura. So the way I usually do, I usually go right in the middle and say about a quarter of patients, which means about 3/4 of patients don't. In fact, patients that have migraine with aura often have migraine without aura. They don't always have an aura with their attack. So aura is not required to actually have migraine disease. All right, it's actually a smaller portion of people that have migraine disease that actually have aura. So myth debunked, hopefully, right? This is where I talk about some of those neurological, and I'll kind of go through this pretty quickly, just to say these differential, like what we think about in neurology. Is this being a stroke? Is it what's going on? And I'll just highlight these things that I have here highlighted. So positive features will distinguish it from a transient ischemic attack. So the beginning of a stroke or a short stroke, right? That's usually what a transient ischemic attack is. Seizure, negative symptoms of migraine, because you know that, is different from seizure, because seizure is usually positive. It's extra movement or activation. And then with transient focal neurological episode, not having a headache, usually distinguish it from migraine, TIA, and or seizure. So, all right, myth 4A and 4B. I stuck an extra one. Okay. So if the head pain is on both sides and in the back of the head with neck pain, it's tension type headache, not migraine. All right. And then the other one, if it's in the front, so if it's in the back, it's tension type headache. If it's in the front, it's sinus headache. All right. Here we go. And oh, yeah, I missed that one. How about this one? And you know that slow one, the slow one. Okay. All right. All right. So wrong. Okay. So this is a common misdiagnosis, and it comes to that point, and I just described the ICHD category, but let me explore that just a little bit more, right? And differentiating the two, attention type headache, because I mean it's a good thought. It is a good thought, but there are some differentiating features that we wanted to think about. Okay, so remember I said that it has to be unilateral. Well, actually, only about 60% of patients that have migraine have unilateral. In fact, as kids is mostly always bilateral, right? And then as people grow up, about 60% of those start to pick a side, okay? So this may not be the differentiating factor, although tension type headache, you may have bilateral too, right? Pulsating. Well, not every migraine attack, headache attack is pulsating. Most of them are, but not all of them. So that's 85% of migraine headache attacks. Moderate to severe intensity, and that is a differentiating factor. So mild to moderate intensity versus tension type headache. Tension type headache is not pulsating, right? And then aggravation by routine physical activity is tension type headache not aggravated by routine physical activity. So those are some differentiating at the first part. And then the second section is looking at the nausea and or vomiting and photophobia and phonophobia. And you can see that so most patients will have one of these two, and there's no nausea or vomiting for tension type headache at all. And then one or neither photophobia, phonophobia is for tension type headache. One of the things too we were seeing, this is Juneteenth, right? And so one of the things that we're actually seeing with the disparity, I actually gave a disparities talk with some colleagues at the American Headache Society meeting. But one of the things that we're seeing, because of the patient population that were involved in different studies, now we're seeing that even with this no nausea and vomiting, that there may be more behavioral changes, meaning that I just don't feel like eating right now versus having nausea, right? I mean, there's different things, and that's why it's very important to be inclusive in studies so that we understand the entire population, right? And so, but thus far, right now, in the ICHD-free version, this is what we have, okay? What about sinus headache? Sinus headache, sign us up for migraine diagnosis, okay? Sinus headache usually means sign us up for migraine diagnosis. But why is migraine and sinus, why is that, something that's very, very commonly misdiagnosed? And why do people think that they have sinus headache? Well, as you can see, there are a lot of similarities between headaches secondary to sinusitis, because that's how it's classified, versus migraine, right? But what's important when I think about sinus, right? Think about the IN, sinus, IN, infection. So you have to have signs of infection, not just to have stuff in this, but signs of infection. So persistent yellow and green nasal discharge, fever, swollen lymph nodes, and things like that for sinus headache. And I did some work with colleagues, and we just kind of reviewed this, but almost 9 in 10 people who self-report sinus headache actually have migraine disease. Okay, and I described this. So there's a nerve called the trigeminal nerve. So tri is 3, geminal is branches. So when people go to the dentist and everything, when they block those things, you hear Novocaine like, and they're literally blocking lower branches of the trigeminal nerve. But that's part of the migraine. The trigeminal nerve is part of the migraine pathophysiology. But where does those things course? Right around the sinuses. Right around the sinuses, right? Now, how would we differentiate sinus headache from migraine? Well, sinus headache is not associated with nausea or vomiting, and not associated with light sensitivity and sound sensitivity. So sensitivity. And so I do get, and I'm seeing some of my ENT colleagues, otolaryngology colleagues starting to see this, and they will refer patients, say, I think that you, after doing, a lot of different things, I think you might have migraine disease. Maybe you need to go see a headache specialist or what have you. But understanding this, you can decrease the radiation that you get and everything like that by knowing this diagnosis. So now, why did I bring this up as a myth, right? Because almost 40% of patients or people living with migraine disease have not been diagnosed. There's these other diagnoses and things like that. And why is diagnosis important? Talked about it at the very beginning. What I didn't say about that hemicranial continua diagnosis is that diagnosis is actually responsive by definition. If it reads the textbook, it is responsive to one medication. I mean, like there's a single medication that is responsive to. So while that patient in my residency had been looking up, and I was the same thing, I was about to do the same thing, have been treated, I'm like, this is chronic migraine. And there are some things on imaging studies that look similar, but knowing the difference, now I can treat that patient, not with all these other things that may have all these potential side effects, all these things that, not giving them quite relief, but with that medication that headache is responsive to. And then we go from there. So that's why, that's how I got into headache medicine, right? Because, oh man, you can really help some people if you actually figure out the diagnosis. That's why sometimes residents don't like rotating with me, because I said, what's the diagnosis? What's your evidence for that? My wife got a joke. She said she's going to give me a t-shirt and say, what's the evidence for that? So, that's right. I mean, that's what we should do. We should, what is the evidence? And we don't have evidence for everything. But for what we do, can we match the evidence? And this is how I practice, try to match the evidence with the patient's preference and things that they want. Can we make a match there? So, and then about half of those diagnosed with migraine have consulted a medical professional in the past year. So, a quick screen, actually, where you just pin the diagnosis, right? It's called ID migraine. It's been validated in multiple countries. Just 3 things, right? So even in a busy practice, like for primary care, because they're taking care of so many different things, right? They're really front line. 3 things, just a screen. Is it photophobia? So do you have sensitivity to light? Is it intense, moderate to intense pain intensity that makes it difficult to function? Do you have nausea? So 2 out of those 3 would be very suggestive. 3 out of 3 really, but 2 out of those 3 very suggestive for migraine. It's called ID migraine. Very quick screens, Mike can fill out real quick. Myth 5. I might like this one. Chocolate would trigger a migraine attack. Okay. Now, right, we're going back, and I've just presented it in a different way. We're going back to those phases of migraine disease. So one of the things I want to point out right here specifically, yeah. All right. One of the things that I wanted to present here is there are these food cravings. We are really starting to understand. Remember I told you about those different places that are activated in the hypothalamus, right? And hypothalamus is stirs and all this. Food cravings. So, and some people, not everybody, but in some people, chocolate is part of their pre-monitor. So they want chocolate. That's a craving for them. So they were going to have that headache attack, whether they ate chocolate or not. That's just part of their primary premonitory. Okay. Now, I mean, and when you think about caffeine, yes, there's a balance with caffeine. Okay. I mean, it's chocolate, you got caffeine, coffee, there's a balance. So for some people, though, it's just part of their migraine disease. They're going to have it or not. And sometimes, because especially people that really like chocolate, every time I eat chocolate, and I'll say, well, is it actually every time? Because it could be a trigger, right? It could be. It doesn't have to be. It could be, but then it could be part of this food craving. So that's why understanding the disease, for me and my colleagues and things like that, we might be able to, now, and I'm not telling everybody just eat a whole bunch of chocolate, okay? But I'm just saying, just watch it. Just see if how many times, like if you had chocolate and you didn't know you were going to, you went to a place and they just had, cake or something, and there was more chocolate. Did you actually get attacked then versus knowing that you got attacked, right? And so I do have people keep headache counters and stuff like that, not with a lot of information, but enough that we can try to identify patterns. So I just wanted to debunk that myth. And we've seen this before as far as the timeline of the attack. I have a category, I call it headache healthiness, that I always talk about with non-traditional, non-pharmacological modalities. And I just put this in because when it does come to caffeine or something like that, it's usually want to limit to no more than 200 milligrams in episodic migraine to avoid transition, and then to a chronic migraine. And then also consider avoiding, I know sometimes it's hard, with a daily. And so this was a table that my colleagues and I put together for like looking for affordable things that what can people do, right? Even, I mean, not necessarily without seeing a physician, but what can you do without seeing a physician? What's this headache healthiness? And I summarize it to my patients because I don't go through this whole table with them, but I summarize for my patients with a word that I call homeostasis. I mean, I didn't name it, but it's called homeostasis. So homeo means all of you are my homies. No, that's not what it means. Okay. Homeo means body. Stasis means the same. So when someone has migraine disease and other headache diseases, things like that, their body really wants to stay the same, right? So you can't be dehydrated, right? You don't want to, your body's not the same, right? You're dehydrated, right? Sleep, right? Good sleeping habits. You don't want to sleep too much, don't sleep too little. Again, I draw this pitiful design of a seesaw. And I say, you really want to try to keep that down. You don't want too much stress. Actually, I probably even have that. You don't want too much stress. Too much stress like that. You really want to even kill as much as possible. So having stress management techniques and things like that. And then diet, not getting, some people have attacks that are triggered by changes in barometric pressure. So they see that with the humidity, or this past week, people come in for their procedures and like, oh, it's been it's been tough, or even if they're flying and things like that in the airplane. So, and then we talked about medication overuse, which is a huge modifiable factor. And I actually see a lot of people with chronic disease that have medication overuse. And so we have to just make sure that those acute treatments are not used more than 2 to 3 days per week in general with that. So that's why I call it this headache health things that you can. And then I do have a bonus myth. So it states that Michigan State is not conducting migraine disease research. And I'll say a big hearty, so we are. All right, so that we're doing research that's community engaged research, looking at disparities in migraine disease, pediatric clinical trials that we're doing, upcoming in collaboration with Henry Ford Hospital. We're looking at some of those calcitonin gene-related peptides and migraine disease. So we got IRB that's kind of in process now. Hopefully we can get that undergoing. Remote behavioral therapies and migraine is a collaboration with my colleagues out in Wake Forest and stuff. So you are actually invited to contact Mrs. Aubrey Alexander. I don't know, here, 517-884-89. Yeah, but if you're interested or her email and more information. And with that, I think that is it. No, that was no, I'm just kidding. I am conclusions here. Yeah, so migraine is often misunderstood and stigmatized chronic episodic neurological disease and chronic disease. Chronic migraine may be a chronic disease, neurological disease. It's highly impactful, right? And there's a lot of burden so burdens from neurological disease. It affects people's work, their family. I didn't talk about presenteeism and absenteeism and all these type of different things that occur with people who live with migraine disease. Some of the newer therapies and things like that are targeting, it gives insight to the pathophysiology, and it also targets parts of the pathophysiology. And then as we appropriately diagnose migraine and optimize treatment, we can make a significant positive impact on the lives, on the lives of many who may experience and live with migraine disease, and then decrease the migraine disease pressure. So those are my blessings over here. Those are my colleagues in the middle. And so for that, with that, I thank you for your attention and want to see if there's any questions I may be able to help. So thank you so much. Oh yeah, that's my thinking. Yes, ma'am.
Now, does the gluten-free diet help?
It depends. If gluten is a trigger for someone, then it likely will, absolutely. But if it's not, it might not, right?
Yeah,
So,
my daughter is, since she was
Her?
young, in the school, and she started gluten-free, but
Should it
I
help her?
don't know yet.
She doesn't know. Yeah. So, some people do an elimination. I don't do elimination diet. It's just not fun, in my opinion, right? I mean, I always try to treat people like I would want my beloved. I would say my family members, but those ones you love, those are the beloved family members, right? And I don't know if I would want an elimination diet. if I can identify, and this is what I tell people, if they can identify what the trigger, yes, then I want you to eliminate it. But even if you do, like, let's say you decide to do like a gluten-free, I mean, see, if you don't notice really any difference, then it may not be that. But if you notice a difference, then stay with it, right? I mean, so everybody's going to be different, right? I mean, there's a lot of heterogeneity and a lot of different ways that migraine express and a lot of different pathways. So that migraine disease occurs.
So is
Yeah.
there any medication now, recent medication?
Well, there's different medications and things like that, but I would advise them to kind of talk with their provider and everything like that. I saw this hand first.
I was just along the line of that, so discuss limits on acute treatments to no more than 2 to 3 days a week. What do you define as an acute treatment?
So acute treatment, great question. So acute treatment are those that it's like I was calling an anti-pain treatment. So so even something as simple as acetaminophen, like over there, that's the active ingredient in like Tylenol, right? That's an acute treatment, right? You take it when I have pain, I take this, right? So it's like when you try to abort, and I usually call it abortive, when you try to abort the headache attack.
So Imitrex would be an example then.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Absolutely. And 10 days limitation on that, by the way. Over 10 days a month, over a 3-month period. So it's not just one time. You have surgery, and so you take something for 2 weeks or 3 weeks, and then you're going to have medication overuse. That's not how it works. But it's usually it's a diagnosis that's over a period of 3 months, okay, with those limitations. And the triptans, that's what sumatriptan or Imitrex, as you say, is 10 days or more a month over a 3-month period of time has been shown to increase headache.
Per month or for 3 months?
Per month. Mm-hmm. But over a 3-month period of time, that's the window that we look at. We can't just take 1 month by itself. We can take it over. Mm-hmm. Yes, sir. Someone was over here. Oh, absolutely. So the first question was a great question because there's people that are watching via video. Oh, they're up here. So the first question was a gluten-free diet, like does that eliminate migraine? So that's where I responded in that way. The other question was, what are the treatments? And I said, we want to talk with your provider because there are a lot of different treatments and as I showed, the different pathways and neuromodulation and everything like that. And then the third question was, is Imitrex or sumatriptan, would that be considered an acute treatment or abortive treatment? And the answer was yes. So, okay. So got a couple here. Cluster headache, how much in common with migraine? It's a percentage of all headaches. So I'm not quite sure about the percentage of all headaches. So there are some different things. I would discuss likely the differences with cluster headache versus the things that are common. The differences with cluster headache is, first of all, cluster headache lasts for 15 minutes to about 3 hours. Okay, so it is a shorter duration. You can have up to 8 of those in a day. Those usually happen, I mean, it doesn't have to, but it usually happens usually spring or fall. All right, those are some when people get into their cycles. Cycles usually last anywhere from 6 to 12 weeks. I mean, somewhere right in there. They're very severe headaches, right? So cluster headache has been deemed like the suicide headache, right? And that's what cluster headaches. And it's more prominent in men, so it's almost the opposite. So it's almost like 2 to 3 to 1. And when women still get it too. But men tend to have it more. Also, the difference is that with cluster headache, you have to have one of the autonomic symptoms. So in your head, that's responsible for tearing or eye redness or swelling or temperature changes on one side of the, usually one side of the head. So you have to have that nasal congestion or nasal running or nasal running, rhinorrhea. So you have to have that as part of that. That's one of the things that's part of the diagnostic criteria. The other thing that helps to differentiate it is that when people have cluster headache, a lot of time, most often they feel like they're just very agitated. They want to move. Right? It's so much pain. I just can't stop moving. I gotta go. Versus with migraine disease, remember part of this, they want to avoid physical activity. That's because it's hypersensitivity, right? So there's hypersensitivity going on in the brain. So I want it dark. I want it quiet. I want it, things like that. So those are some of the things that differentiate cluster and migraine disease. I'm gonna go to the next one. Migraine in the eyes or fuzzy horizontal eye. Specialist said migraine. I'm not sure what migraine in the eyes is, but if it's the aura, as I kind of presented, that you can't have different orals. There's such thing as a retinal migraine, but that actually has criteria. It's usually monocular, meaning one eye only, and things like that. So it's possible, definitely possible. Does treating during premonitory period give a better outcome? Oh, great question. The reason why I say that's a great question is any research on using the other no, there's these different GLPs and things like that of treatments for weight loss and things like that. There's not to my knowledge, no. But I want to get this first question because it is absolutely changing the way that we are treated. And so this question is, does treating through a premonitory period give a better outcome? Up until, I would say, less than a year ago. I mean, that's how fresh this is. Up until up to a year ago, there have been studies that looked at treating during the aura or treating during, premonitory, if people can guess it, or things like that. And some of the triptans, right? I mean, it just didn't work, right? It didn't work. You had to wait to the onset of the headache, right? You wanted to get as close to the onset of the headache. However, with the onset of some of these other CGRP receptor blockers, so the CGRP receptor blockers, there was a study that's been presented, it's not published yet, but it's been presented that looked at in the premonitory phase. And now people could avoid their attack with the CGRP calcitonin gene related. I think the battery's out. Yeah, I think the battery's out. So although it still looks like it's but with these
Did somebody turn off something?
something from the stream. But anyway, I don't but to answer this question, I don't need the screen or what have you. But so this has revolutionized track. People that could predict their premonitory. You can't always predict, but those who knew it and everything, they were able to eliminate the headache attack by catching in that phase. That is a revolutionary deal. We think that is I think it was done with ubrogepant, which is a receptor, CGRP receptor blocker. And but I think that's a class-based thing. And what this shows to me, what this means to me, is that as we start to look at the pathophysiology, sure, remember a lot of our treatments we borrowed from other diseases. I mean, like, oh, it worked here, it worked, and some of those treatments still work, or what have you. But I don't have high blood pressure, but for my mom who does, right? And I think my mom, right? She don't always tell me everything. So, but I would want something specific to blood pressure. I wouldn't want a anti-nausea medication that happens to lower blood pressure, because some of them do, right? And so I guess you can treat the blood pressure by this other medication. I would want something specific for my disease. And that's what we're finding. These things are, these molecules and injections and even some of the neuromodulation devices are charting the pathophysiology. So they're being very specific to the disease. And so now, because of this disease process, we're starting to see this evolution of how we treat and when we can treat. So that was a good question. That get me excited on that one. What are the best medication for migraine? So it's not migraines, right? Because it's migraine attack. Just like we wouldn't say people have multiple sclerosis. Think about it that way. Or they have Parkinson's disease, right? They have multiple sclerosis with relapsing remitting attacks. They have Parkinson's disease with freezing, or Parkinson's disease with shuttling, or whatever the case, brain amnesia, or whatever the case is, right? They don't have Parkinson's disease, right? Same thing with migraine. you have migraine disease, but you may have the auras, or you may have the headaches, headache attacks with the migraine. So, but the best medication, it depends on the person, right? It really depends on the person. There's a lot of different things. I like to use a comprehensive treatment approach where I'm using acute, and I'm using prevention, but I'm also using non-pharmacological modalities. And there's been some evidence for decades, like things like cognitive behavior therapy and biofeedback and level A evidence that is not commonly, I don't see like a lot of people commonly using those things. So it's a multiple amount of treatments and things that are available there. A good resource is actually the American Migraine Foundation. If you want to look for like different specific treatment, the American Migraine Foundation is an excellent resource to learn about migraine disease, but also other headaches. And that was kind of birthed out of the American Headache Society, kind of the almost like the patient arm and education arm of the American Headache Society. Migraine without pain. So so blurred vision is a little non-specific. So I won't be making diagnosis. Someone asked me about blurred vision and diagnosis, but I will say that sometimes blurred vision can happen with migraine disease because of some of the autonomics that are involved. So some people can have autonomics with their migraine disease. Is migraine is vertigo associated with not migraines, right? We just also with migraine disease, right? And yes, it is. It can be. It can be. It's one of the, actually, when we look at vertigo, there's a lot you can have, different causes of vertigo. Migraine is not the number one cause, but it's still one of the top causes of vertigo. So what does it mean if you have regular auras 5 times a year with no headache? If you have auras without headache, you have auras without headache. There is a diagnosis of aura without headache. As long as you have met at some point the other criteria of migraine disease, you can have aura without headache. There's a diagnosis for that. Hereditary factors, yes, we see that this is higher. We see that migraine disease is higher in monozygotic twins versus digotic, meaning that it's higher in families. We see it run in families. It can happen sporadically, but we see it higher frequency in people that have families that have migraine disease. Yes. So I think that's all the questions I got.
Thank you, Dr. Charleston. Round of applause, please.
Thank you so much for having me. I really appreciate it. And thank you for great questions too, by the way. Okay. Okay. Yeah.